First of all, thank you very much for this invitation to come here, and thank you to Ahmed for our friendship and since a long time at the UMS. At the beginning, the talk you gave to me, Ahmed, was the artificial intelligence in modern vascular practice, and mainly on the SFA, and exactly what I did. I want to tell you a story. I have no disclosure, and we are talking about innovation, and I am a surgeon, and my job normally consists in treating patients, but I'm curious. I like research, and the question also is, could we be part of innovation? You know the pathology we treat atherosclerosis, but is there only one anatomical presentation, one is histological type of lesion? We have the answer. On a technical perspective, all the devices that make the opening of the artery feasible, we have the different devices, and also devices to keep it open. And we also have the healing perspective, and do we have some technologies that could allow arterial healing for the long run? We all know that we have different presentation of atherosclerotic plaque. We have concentric calcification, we have nodular calcification, we have different fibrous cap or lipid core. But when we treat our patient with critical limb ischemia or PAD, we have a very high-level imaging tools, and depending on the imaging, we do open surgery or endosurgery in a very technological environment. But during the procedure, even in a hybrid room, you use it as a standard camera, because we do not know what we have inside, but we only have the targets above and below the lesions. Then, depending on what we see, we use different materials. What about clinical performances? If you read the literature, you see that finally we only take care of the length of the lesion, of the occlusion, and the degree of stenosis. The length seems very important. We have that in different studies. Here, this studies in the Impact Admiral. But also, we sometimes take care of the level of calcification. We heard about that just before with this Fanelli classification. Then I think it's very important to know if we deal with butter or rocks inside the SFA. Which devices do we have? We have a lot of devices proposed by the industry, but actually who decides to use one or the other one? I would like to make a parallel with other pathologies about the best treatment. If you have lung tumors and you have 2 centimeter diameter tumors and another 6 centimeter, you do not do any histology, and you decide to propose a treatment only depending on the size of the tumor. I think it could be dangerous. It's exactly what we do. We have the length. We do not know what we have inside, if we have butter, or if we have rocks inside. We have a huge technology for CTA acquisition. We can work on the media, the timings, the reconstructions. We can read lower limb CTAs with all you know. We can also try to do some plaque analysis. You can have different level of images, but do we use it actually? I'm not sure we use it. We only, as I said before, we only use the black and white on the hybrid room. Then how AI could help? We think that we could get a perfect knowledge about the pathology of the patient lying on the table, a perfect knowledge about the characteristics of the devices we should use, and a perfect knowledge of the clinical performances. With the images, you can predict outcome after treatment using some quantitative and qualitative analysis of the plaque, as you can see here. You can guide treatment depending on the characterization of the plaque. You can advance pre-op imaging, leading to a precise plaque characterization and the best choice of the device. We started working a long time ago to try to characterize. It was the first step we did, and to evaluate the amount of calcifications as well as the characterizations of this calcification. We tried to see if we had differences in the SFA. We know that, but we would like to have some objective data. And we, at that time, proposed 4 types depending on the diameter of the vessel as well as the amount of calcium inside. This is what we did at that time. We found 4 types, but it was only on the MIP projections. Now we try to use AI to go further. And we first did, in collaboration with 𝗏𝗏𝗏 in Gettysburg, we did some evaluation of the pathology and multimodality imaging for this lesion on the SFA, mainly when they are stented. We have explant. You know that it's my hobby, and if you have explanted graft under graft and stents, please send it to us. We have the pre-op CT. We have the faxitron images to evaluate the amount of calcification, and finally, we have the micro CT. We have these segments collected, of course, after transfemoral amputation, and we did histopathological analysis on these segments as well as multimodal imaging, and we were able to analyze the stents on the interaction with the arterial tissue. We published that recently. Here, you can see different images. Is a CT, micro CT. You can see the differences you have in terms of accuracy, and this is the histology at the same level. And it's interesting to see that we can have information. Here we are in the subintimal space. This is a thrombosed SFA. Then the idea was to go using AI from the image to histology. This is also a paper we published. You have here faxitron. You have the reconstruction using the standard CT, micro CT. And you see at the same level the histology, micro CT, and CT. Then we started working to be able to read histology from micro CT. And our objectives were to create an original approach for automatic atherosclerotic plaque component segmentation on micro CT. In other words, we wanted to teach micro CT to read histology. This is our methods. It's have been published. And what we try to do is to evaluate on the micro CT the different classes of material we have in. And we annotated a lot of thousands of images in order to teach. Here's the histology, micro CT at the same level to differentiate all the material we have in. Next step was to evaluate the accuracy of the CNN and to control all this precision about precision recall curves, ROC, and so on. And this is the AI models, the U models that is very well known. And as these preliminary results, we have now more and more arteries. We had different lesions. We have 5 males, 1 female. The length of the lesion was 13.8 centimeters. We were able to do the histological evaluation, and we were able to evaluate at the site of the culprit lesion all the characteristics depending on the external or internal lamina. Then we try to analyze, the differences we have here, the prediction between the predictor classes and the true classes, and we had very good prediction on mainly on the fibrotic tissue and calcification, but not for now on lipid core. This is what we did, and now you can see here the original micro-CT, the prediction, and the truth on the plaques. This is something we are working a lot here, and you can see we have a very good prediction model. Now we are able on a segment to have 3D reconstruction of the different components. And this is something we have, actually we can have a 3D aspect of the lesion depending on the material we have in. Then we transform the images in a mathematical model. The next step is to go from the standard CT to histology. It's obviously more demanding. It means that after teaching the micro-CT to read histology, we would like to teach standard CT to read micro-CT. And we are working also in image analysis and AI. As you can see here, here you have the micro-CT, and you have the corresponding images on the CT, and we are working with super pixels to have more precise and accurate images. Then this is the next step, and probably something we could do in the future. Then, where are we now? I think that we can have for the future more information about the lesion we treat and the segment, and not only working on the length of materials. We can also, depending on this model, we can choose the best guide wire or instrument, a balloon. We can know if you need to use a atherectomy or not, or also to use the best type of stent, depending on the mechanical properties, because they do not have the same. We tested that, and also using or not drug-eluting technologies. In conclusion, I think that we still have a lot to learn to optimally treat SFA. We treat it on a very basic approach. The length of the lesion is too rudimental for decision making. We must know what we have inside, butter or rocks, and we need to have this preoperative knowledge of this lesion, and artificial intelligence could be a way to develop all these things. On the side, we are developing a specific device to evaluate intraoperatively the mechanical properties of the SFA that we would like also to connect to the image in order to predict from the preoperative image the mechanical properties of the arteries before and after ballooning. Thank you very much. If you are interested in technology innovation, it's my pleasure to invite you to the ESVB meeting we have every 2 years. It's only technologies, and you have prizes for young researchers. Thank you very much.